Welcome. My name is Professor Jonathan Cooper. I work at the University of Glasgow, and I'm here to talk about a project that we have, which is called Quest. And Quest is a multidisciplinary project which is concerning diagnostics and sensing of individuals in the community with a view to being able to monitor health and well-being. So I'm going to share a short presentation with you to explain a little bit about Quest and what some of the ideas that we have are. So, as I said, the project is called Quest and it's funded by our UK government, and the remit is to revolutionise health and care within the community. And as a project, today there will be three people speaking to you. There'll be myself giving you this brief introduction, and then there'll be Terry, who is a clinician working within geriatric care, and also Katie Gallacher, who is a GP who is also interested in community diagnostics and the impact that new sensing technologies can have on how we look after and care for our most frail and most vulnerable people. The project is highly disciplinary. I'm actually from the engineering sciences and work as a biomedical engineer. I've already introduced Terry and Katie, who are in medicine, but we also have a large input from social scientists, particularly in healthcare economics, in understanding the impact that the new technologies can have on healthcare and the cost savings which can be brought about. Within the physical sciences, in addition to engineering, we have inputs from quantum physicists, as well as people involved in computing science, using advanced analytical techniques to look at patterns of behavior and how people behave within their home. So here is a very simple demonstration or schematic showing the kinds of technologies that we're developing. And in this case, we're simply shining a light onto someone's neck. And as a consequence of the reflections which we can measure with a very sensitive camera, we're able not only to be able to determine their heartbeat, but actually we can look at the dynamics of how their heart is behaving. And you can see actually on the right-hand side here, we have results which come from a stethoscope, which your GP might normally use to monitor your heart. And you see that with this new technique, we can get very, very much more detailed information, which we can quantify relatively easily. So imagine if we were able to put this technology into a home, so that if it was someone who was frail or elderly, we were able to monitor their heart pretty well round the clock in order to be able to see whether they were struggling, whether they were asleep, whether they were awake and doing exercise, or whether they were sedentary, and to monitor their health as well. So when you go to the GP, it tends to be quite a stressful event. It tends to be one in which your cardiovascular output changes. You might actually exercise when you go to the GP. You might need to walk there. There's a degree of stress and so on. And you don't really see the heart in its normal resting state. And of course, the measurement is made as a one-off measurement whilst you're in the GP. This kind of technique affords the opportunity for continuous monitoring remotely in your home, producing information which is not in any way personal or insecure. And here's a second example. You may well have a mobile phone network, or indeed have a Wi-Fi network at home, and that Wi-Fi signal, which permeates through your house, actually can also be used to tell whether or not you are moving, whether you're sedentary, gives you quite strong indications as to your behavior. And actually, exactly this kind of work, coupled with the work that computing scientists do to monitor whether you're listening to the radio, patterns of behavior in the house, how you're accessing TV, when your lights are switched on, when your lights are switched off. We're able to look at these patterns of behavior, and as a consequence of that, be able to say something about lifestyle and health and well-being as well. So that's a very brief introduction. But following me, there will be talks both by Terry and by Katie, who will give more information. Thank you.
Hello, everyone. I'm Terry Quinn. I'm a consultant in older adult medicine, and I'm based in the Royal Infirmary, and I'm also part of the Quest team. So what I want to do over the next 5 minutes is tell you a little bit about my job, some of the limitations of how we practice medicine in the hospital, and perhaps some ways that new technology may help us, but also think about some of the questions there. So I work in the older adult services and I love my job. I get to see people who come in very unwell, and along with that illness, they often have physical problems. They may not be walking so well. They may not be as strong as they want to be. And sometimes they have memory and thinking problems also. And I work with a team not only to get them better from the illness that they came into hospital with, but also to get the consequences of that illness better. So to get them stronger, to get them safer on their feet, to get them able to do the things they want to do. So it's all good. But there are some things that perhaps could be done better. There are some limitations to the way that we traditionally practice older adult medicine in hospitals. And the first obvious thing is it's done in a hospital. Hospitals are good, but they're not local. Sometimes they can be quite far away from the visitors that you want, far away from the loved ones that you might want to be with you. Hospitals work to their own routine and their own regime that might be quite different to what a person is used to. And so hospitals aren't always the best place for an older adult to recover from illness. And we know this now from scientific studies that have shown that you can deliver a lot of hospital care actually in a person's home. And throughout the UK, people are looking at how they can try and give all the care that's available in a hospital in the place that the person wants it, which is usually their own home. Another problem with hospital medicine is it tends to only kick in when there's a crisis. And in older adults, illnesses tend to present with crises that are fairly typical. No matter what the illness is, when older adults are unwell, we see things like they may have falls, or they may become confused, or they may simply take to bed and not be as active as they were before, or they may suffer from incontinence. Traditionally, we wait until those things happen and then we try and treat them. But wouldn't it be better if we could prevent those things before they happened in the first place? Another issue with hospital medicine in general is it tends not to treat the person as an individual. We work to guidelines and protocols that are designed for everyone, but we know that within a group there can be big differences. So here we have two men of a similar age, but very clearly one of them is more robust than the other. And the best treatment for one of those men could be quite different to the best treatment for the other man. Another issue in hospital medicine is what we try and achieve. So as doctors, the things that we would traditionally try and do would be to keep people alive, to stop them having heart attacks, or we would maybe look at measures such as a blood pressure or a pulse. And they're all important, but they're not always the thing that's most important to an older adult. And we know this because we've spoke to older adults and they've told us, while those things are important, of more importance to them are things like staying out of hospital, not having to go to a care home, not having treatments that are very, very burdensome and that interfere with their daily life. They want to stay independent, and most of all, they want to avoid dementia. Another consideration around the medicine that I practice is it hasn't changed much in the last couple of 100 years. The equipment we use, the examinations we do, really are pretty similar to how they could have been many, many years ago. With new technology, could we do things better? So the way we do things now tends to be remote, generic. The agenda is very medically driven. It's reactive to crisis. And some of the technologies we're using might really be obsolete. And I would like to reimagine things and think about care that could be delivered locally, that's individualized and that's person-centered. Care that's proactive and preventative, rather than waiting until the person has a problem. And care that uses the very cutting edge of technology. Now, in fact, some of this is happening already. And you might already have an Apple Watch, or you might already have a home blood pressure monitoring kit. But with my colleagues in the University of Glasgow, we've went even further than that. And we've started to develop technologies that can give us really detailed information about your health without even having to wear a device, without you having to go into your phone. The technology assessment can happen without even being aware of it, and it can generate lots and lots of information that could really help us predict problems and intervene before they come to crisis. So that all sounds very good. And people that are early adopters of technology will be pleased that the kind of technologies we have are unobtrusive. They allow continuous monitoring. They'll generate lots of information. But there are concerns as well, and I can see that there could be concerns. People would be worried about being assessed without them being aware. They might think about Big Brother is watching you. Technologies are good if you're comfortable with technology, but a lot of older people aren't comfortable with technology, and they may feel excluded from this. If technologies are replacing medical assessment, does that mean that that person won't see anyone? Could they become isolated? And if we're generating lots of information, will doctors even know what to do with that? So there are big, big questions there. And those are the questions that we are hoping to answer with the Quest study. The Quest study is not only about developing the technology, but it's about speaking to people that are living with chronic conditions to find out what their opinions are on the technology, whether they would use that technology, and how we can adapt the technology to really meet their needs. We're looking to involve as many members of the public as possible to help us develop the technology. And in another talk, you'll hear details about how you can become involved. So I've been Terry Quinn, and thanks for listening.
My name is Katie Gallacher, and I'm a GP in Glasgow. And I'm going to be talking for about 5 minutes on how new home technologies can possibly help my patients. Over the last 2 or 3 decades, we've seen changes in society. People are living longer. More people are living with long-term conditions such as diabetes and high blood pressure. More people are living with obesity. And we are seeing more frail people. Because of these changes, health services have had some challenges. For example, health services are busier than they were before. And because people are more frail and more elderly and more unwell, it can be harder for them to access health services. We are already seeing technology providing us with some potential solutions to our problems with healthcare services. For example, in the past, to get your blood pressure checked, you had to go down to your GP surgery to do this. But now, many patients are checking their own blood pressures using devices at home and sending recordings in to their doctor or nurse. I'm going to go through 4 common problems that I see as a GP in my day-to-day practice, and then talk about how home technologies could possibly help with these problems. The first common problem is that by the time I see people, they have often developed a condition, rather than me being able to prevent this developing. This, of course, leads to worse outcomes for patients and more treatments. One possible solution here would be that home technologies could monitor people at home to pick up medical conditions earlier. For example, if you were able to monitor your heart at home, then you'd be able to pick up warning signs earlier, and this would prompt further investigation. The next common problem is short appointment times. Now, I'm sure this resonates with a lot of people, GPs, nurses, and patients alike. When you see your GP, you only have 10 minutes, and this can make it very difficult for patients who have a lot of things to discuss, and also very difficult for doctors, who can find it hard to build up a full picture in that time. As a result, it may be possible that something could be missed in more complex cases. So, for example, if you're seeing somebody with a sore throat, this can easily be done in 10 minutes. If there are more complex issues to discuss, such as worsening mobility or problems with memory, then it may be harder to do this in a short 10-minute consultation. Sometimes we may be worried about patients and end up admitting them to hospital for further monitoring because we are concerned and we are unable to monitor them for a longer time within the practice. So one possible solution that home technologies could help with in this situation would be to allow us to evaluate patients over a longer period of time in their home. The next common problem is monitoring after hospital discharge. Being in hospital can be a difficult time for patients and families alike, and often when patients are discharged, this can be a time of worry. Patients and families worry about the safety of the person at home after discharge from hospital. So one possible solution here would be that home technologies would allow us to monitor people for a period of time after discharge from hospital to ensure that they were safe in their home. The next problem that we commonly see is that some patients find it very difficult to access healthcare. This could be because of a physical disability or because of a more hidden disability such as low mood or difficulty with memory. So one possible solution here would be that home technologies monitoring at home would lessen the need to attend healthcare settings, a little bit like what we've seen with blood pressure monitoring being done in the home rather than in the GP's surgery. So these are all ways that home technologies could help look after patients in primary care. However, there are some points to ponder. For example, will people accept these new technologies in their homes? What mechanisms are in place to allow individuals or healthcare professionals to provide feedback on these technologies? And what are the potential disadvantages of them? For example, will we perhaps overdiagnose people with medical problems, and will this lead to overtreatment? These are all things for us to consider. Many thanks for listening, and if you have any questions, myself or Francis Mayer would be delighted to answer them if you would like to email us, and please do follow us on Twitter. Thank you.
Hi, it's Terry Quinn again from the Quest team. So you've heard lots of talks now about the Quest project. You've heard about the technologies we're developing, and you've heard about how they could help hospital-based doctors and GPs. And through all the talks, the speakers have emphasised that we're not doing this alone. We want to work with the people that might be using this technology. So people that have chronic conditions. Because at the end of the day, we're developing this technology to help people that have chronic conditions to stay healthy, to stay active, to stay independent. Now, this whole idea of working in partnership with people is relatively new. Here's the traditional way that people would do research. They would have an idea. They would then get grant funding. They would then get patients, if I can use that word, into their study, and then they'd write up the results. And the only bit that involved any kind of engagement with the people that might benefit from the research is this bit here, where they recruit people in just to have them in the study. But we think we can do better than that. And we think that actually working with people that have chronic conditions will make for better research. Because that old model has a certain power dynamic. You have your experts in their ivory tower here, and then you have the public, the people living with conditions, the people that matter here. And we used to assume that these people were the experts, but actually, there's two different experts. There are the people that have the technological expertise, but then people living with the condition, they bring their own expertise, and they bring a knowledge that these people could never have. So in the Quest study, we're very much about working with the people that may want to use the technology. Here we've got two young clinical researchers. And the thing that I always say to my kids is, you've got to listen. And that's what we're trying to do. That's what we're trying to do in the Quest study. And when we listen to people, it sometimes challenges what we thought we knew. So in other research studies that I've been involved with, when we were setting them up and designing them, here are some things that people said. They said, oh, you don't want to bother people that are living with chronic conditions. They don't want to take part in research. They said, don't approach people's caregivers. They're far too busy. They said, if people have mobility problems or memory issues, they won't want to do research. But actually, when we asked, and when we listened, we found that people do want to at least have the opportunity to be involved in research and to have the opportunity to work with researchers. It's not for everyone, but people want to be asked. So that's our ask, is whether you could help us in the Quest project to make sure that our research is the very best it can be. And you can do that in lots of ways. You might want to join a group of people who could discuss some of the new technologies we're developing, and together you could give us guidance on how we might make it better. Or you might want an individual interview with one of our research team, looking at a new technology and giving your opinions. Both give us really useful information. You might want to come up to the university and try out some of the new technologies, give us your user experience. Or when the technologies are more developed, you might want to take them into the house and see how they work there. You might want to help us with the conduct of the study itself. So you might want to help us designing materials that the public will see to make sure that they're understandable, that they're not filled with the kind of jargon that sometimes scientists and clinicians can lapse into. And at the end of the project, when we have results, you might want to help us interpret those results. We will interpret them from a scientific point of view, but we want to know what the people that might use the technology make of our results as well. And these are only some examples. There are lots and lots of ways that you could work with us on this research project. Now, I know you'll have lots and lots of questions, and apologies that we can't meet in person to answer those questions. But here are the answers to some of the questions that I'm frequently asked when people are thinking about helping with research. This is voluntary. If you approach us and you find out more, then you decide that the project isn't for you, that's absolutely fine. Learning more about the project isn't you committing to anything that you don't want to do. The project's going to run for a number of years, but you don't have to be involved for that whole time. You can help as much or as little as you want to. Some people might want to help just one aspect, and other people might want to help with lots of different aspects. And depending on your circumstances, depending on your availability, there might be times when you're available to help, and there might be other times that you tell us you're not available, and that's absolutely fine. Fundamental to this is you will not be out of pocket from helping us with the project. So we will cover travel. We'll make sure that you get something to eat and drink if you're in a long meeting. We'll make sure that the rooms are accessible if you have mobility issues. And on top of that, we recognise that you're giving your time to help us, so we will provide compensation for your time. And ultimately, I hope it might be quite good fun to work with us. So how can you find out more? Well, we have a website, healthcare-quest.com. You can find more information there, and there's a button that we've labelled public and public engagement that will tell you more about the project. And we're working with our partners in Alliance. And Alliance will also be able to tell you more about the project and direct you to the research team here. So I'm going to show good manners like I ask my kids. I'm just going to end by saying thank you. Thanks for listening. And if you're interested in the project, thank you. So I've been Terry Quinn. Thanks for listening. And I hope to hear from you. Bye for now.